Okay, thank you very much. Thank you for all coming out this evening. It's always great to see so many people. My name's Andy Wright. I'm going to be the independent chair for this meeting. And it's very important to stress that I am independent. I neither work for the NHS or live in Cumbria. So therefore, I have no particular interest in this. I'm employed by the Consultation Institute, and my role throughout this is to ensure that everybody gets a fair hearing and they get the opportunity to talk, and that we also have the opportunity to hear what NHS colleagues have to say. We're here today to discuss the future of healthcare in West, North and East Cumbria. The consultation documents are at the back of the room, if anyone hasn't picked them up. A lot of people will have had a look at them, but if you haven't, it provides you with details of the mechanisms to take part in this consultation in other ways apart from this meeting. A couple of things I need to say, first of all. There is no fire alarm test scheduled today, so if we do hear it, please exit through the clearly marked fire exit doors. It would be really nice if you could hang around just to make sure that everybody got out safely. We'll congregate in the car park, but apart from that, I'm not expecting anything. There's toilets there, we're all grown up, so if you need to use them, please do. Throughout this, there's a couple of things that are really important to me. And I apologise for that part of the audience that can't see me, because if I stand forward of this, I get feedback. So, yeah, so I'll keep moving around so you can see me. Couple of things. I welcome tough questions. It's important that we ask the tough questions, but it's also important that we respect each other. So please allow time for people to respond to your questions, and please allow people room for other questions. To help me manage this, I think there's it's very important that you all get to speak, because this, you've noticed there's a professional sound team here, colleagues over there. This is being recorded for the record. So when you want to ask a question, I would ask that you raise your hand and make sure that I've seen you. I will arrange for one of the microphones to come across to you. Please wait until you get a microphone to you before you start speaking, because that question will be recorded, as will the responses, and it forms part of the consultation evidence, very importantly. Now, if you start talking across people, or you don't talk while we've got the mic to you, you might be asking the most important question in this entire meeting. And if we don't hear it, we don't get it recorded, and it kind of loses the point. So please bear with us a little bit while we manage the logistics of getting the microphone to you. I will make sure that everybody has the chance to hear. And speaking of hearing, for those of you that need to, there is an induction loop for hearing aid users right the way round the room, so you should be able to pick it up on that. I'm not going to introduce each of the speakers, because on the panel I'll forget who they are. So I'm going to ask them to introduce themselves, and then I'm going to hand over to Stephen, who's going to give us a presentation. So, going this way.
Okay. Good evening, everybody. My name is Andrew Brittlebank. I'm Medical Director of Cumbria Partnership Trust, which is the organisation that provides mental health and community services to the county.
Good evening. My name's Rod Harpin. I'm both an anaesthetist and intensivist, and also the medical director of the Acute Trust.
Hello everybody, my name's Carol Davis, and I am responsible for paramedic emergency services for the North West Ambulance Service in North, West and East Cumbria.
Thanks, Carol. Good evening everyone. My name is Stephen Childs, and I'm the Chief Executive of NHS Cumbria Clinical Commissioning Group. And the Clinical Commissioning Group, or the CCG, is responsible for overseeing and delivering the consultation process. And ultimately, come the spring of next year, the governing body will be making a decision based on the feedback. But I shall tell you more about that in a moment. There are some spare seats down here if any of you are struggling to see the screen, just to give it. You okay? Splendid. So let me work through the presentation, after which, as Andy says, we'll have plenty of time for questions. I have a couple of slides on the consultation itself, and I think it's really important that I stress from the outset that no decisions have been made. That's really important for people to understand. I've been aware right from the outset that the integrity of the consultation has been questioned. So I want to give you my assurance, my word, that no decision has been made, and that's why we're here tonight with you to hear your views. And we are really keen to listen to you, to understand what parts of what we're consulting on you support and what parts you don't. And very, very importantly, whether you have any alternative suggestions, not just tonight, but when you go home and think about it, we would strongly welcome you to submit your ideas, and they will genuinely be taken very seriously. Further reassurance is that the outcome of the consultation will be independently assessed. So the clinical commissioning group doesn't directly receive the feedback. It goes to an independent assessor, and the clinical commissioning group receives the feedback from the independent assessor. As I said, no decisions were made this year, not until more than likely the spring of 2017, in order that all of the feedback, not just from the public and patients, but from many of the interest groups and the professional bodies, from clinicians, can be taken into account. It's probably important also just to point out the fact that whilst this is not a vote, it's not a referendum, we've probably had enough of those for the time being, it is a really important mechanism for you to feed back to us. So it's a more constructive dialogue with the people that matter most, the people who receive the services. So, let me just turn to some of the challenges that we face, and they are very, very significant challenges. The population health of our community is not great. We have some real challenges recruiting clinicians, medics, nurses to vitally important posts in order that we should be able to deliver safe services. We have too many people that rely on hospital beds and end up staying in hospital longer than they really should. And the NHS as a whole is significantly challenged financially, and that won't be news to you, I'm sure. And the Care Quality Commission, the CQC, the regulator that oversees the quality of services we provide, feel that many of our services are less than good, and some of them are in fact deemed to be inadequate. And clearly that's a situation that we want to change. I also appreciate that some of the challenges that we're trying to resolve have been very long-standing, over 10 years. And that situation, that uncertainty, is compounding some of the problems we have. It certainly isn't helping us with recruitment, and it means that we really do have to tackle these issues once and for all. That will inevitably require us to make some difficult decisions, I don't doubt, down the line, but we need your help to make those decisions. We believe we have, good evening, we have a very compelling vision for the future. We want West, North and East Cumbria to become a centre of excellence for integrated health and social care provision in rural, remote and dispersed communities. We want our community, our health and social care community, to become something of a beacon, such that people are attracted to work here because it's the best in the country. And we believe that we can achieve that. And at the heart of it will be our 2 hospitals, as well as integrated community teams. So let me just turn to those integrated care communities. We're not consulting on the ICCs, the integrated care communities, but they are fundamentally important and will create the critical infrastructure to allow us to transition and move services from acute care settings out into the community. We're talking about joining up the care that's currently provided by community services, primary care, general practice, mental health services, the community and voluntary sector, the independent sector, and social care, focusing on populations of between 20 and 70,000 people, ensuring that people are able to remain independent for longer, keeping them out of those hospital beds, and if they do have to go home, go to a hospital bed, we aspire to get them home quicker and more safely and more quickly. So the combination of our integrated care communities and the proposals for change in the consultation document will, we believe, lead to safer services of a higher quality that are clinically sustainable and also financially sustainable. So let's just turn to these potential service changes that we're considering. First of all, let's take children's services. We have a major problem at the moment with paediatric consultant recruitment. It's not unique to Cumbria. It's a national problem. In fact, I even understand it's an international problem. I understand that of 5 posts currently, we've barely filled 1 of them. And that clearly makes it incredibly challenging to deliver a safe service. What we aspire is for a whole system children's service where we have more support in the community and we have less need for beds, in line with advice from the Royal Colleges. Today, for example, more than 95% of children with acute illness can have their needs met in the community. They don't need to be in a hospital bed. So the options that we've been considering are these: that inpatients continue at Carlisle and at West Cumberland, but only low risk at West Cumberland overnight, with short stay assessment at Carlisle and at West Cumberland. Second option, inpatients at Carlisle with short stay assessment at West Cumberland and at Carlisle. The third is full consolidation of children's services at Carlisle with paediatric outpatients only at West Cumberland. Now, the preferred option is option 1, inpatients at Carlisle and West Cumberland, but low risk only at West Cumberland overnight, and short stay assessment at both Carlisle and West Cumberland. Turning to maternity services, one of the knock-on effects of finding it very difficult to recruit paediatricians are the implications for maternity services and a safe consultant-led maternity unit. That recruitment is also compounded by difficulties recruiting mid-grade obstetricians. So our options that we're considering, first of all, important to stress that all antenatal and postnatal care will continue at both West Cumberland and at Carlisle. But the first of those options, which would be a consultant-led maternity unit at both hospital sites, Carlisle and West Cumberland, would still require the higher risk births to take place at Carlisle. The second option is for a midwife-led unit only at West Cumberland, and the third option is for full consolidation of all maternity services at Carlisle. And the preferred option is the second one, and that is for a midwife-led unit only at West Cumberland Hospital. Turning to community hospitals and the inpatient beds, first of all, really important to stress that none of the proposals consider closure of any of the community hospitals. All of the community hospitals will remain open. Just a bit of background. According to national averages, at West, North and East Cumbria, the population would merit somewhere in the region of 84 beds. And we have far in excess of that at the moment across our community hospitals. And the proposals, the different options, actually accommodate 104 beds, including those for end-of-life care. So just some, I think, useful context to the number of beds that we are considering in our community hospitals. So there are 4 options that see a consolidation of those inpatient beds. The first on the list is to consolidate over 6 sites at Whitehaven, Cockermouth, Workington, Penrith, Brampton and Keswick. The second option is to consolidate those 104 beds over 5 hospital sites, not including Workington. The third option, which is a different configuration of the 5 hospitals, would see no beds at Cockermouth. And the fourth option is to consolidate over 3 sites, perhaps the most controversial, which would only see inpatient community hospital beds at Whitehaven, Penrith, and a new site at Carlisle. Now, the preferred option is option 1, which is that consolidation of beds across Whitehaven, Cockermouth, Workington, Penrith, Brampton and Keswick, which therefore would see beds closing at Alston, Maryport and Wigton. Now, what I would strongly encourage you today and all of your members of the public who attend these meetings and show an interest in these proposals is to give serious consideration as to how you would like to see your community hospital run in the future, because there's no suggestion that there isn't a role for community hospitals. It's just how do they fit into a modern health and social care service to meet our needs better in the future. So no doubt we'll come back to that, I'm sure, in the questions and discussions later. Emergency and acute care. Well, first of all, I think very importantly, we felt it was vital to protect the concept of 24/7 accident and emergency services at both sites, both West Cumberland and at Carlisle. But nevertheless, we need to make those services clinically sustainable, and we do face, yet again, some very significant workforce challenges in acute and emergency services, accident and emergency services, with some 40% vacancies in certain clinical disciplines. So we're proposing a new workforce model that sees much more specialised roles for nurses and paramedics, and we believe this will be groundbreaking workforce development, and we have the backing of the professional bodies and the clinical senates for the changes that are suggested. So the 3 options: first of all, 24/7 accident and emergency services continue at both West Cumberland and Carlisle. Secondly, 24/7 urgent care centre and daytime A&E at West Cumberland with full services maintained at Carlisle. And then third option would be a 24/7 urgent care centre at West Cumberland Hospital with A&E at Carlisle. The preferred option is option 1, which is for 24/7 A&E at West Cumberland and at Carlisle, but stressing the need for those clinical workforce developments that enable us to provide sustainable clinical services. Finally, stroke services. What we know is that stroke services currently are not as good as they should be and not as good as the people of Cumberland deserve. Neither hospital currently has a dedicated stroke unit, and by 2021, we anticipate that the number of people suffering from stroke will rise from 600 to 700 a year. That clearly would be very hard for us to manage with the current configuration of services. We are not currently meeting quality standards, so we need to do something about that. We are also finding it very hard to recruit enough stroke specialists to service both hospitals. With either option, rehabilitation services will continue at both Carlisle and at West Cumberland. So the 2 options are to continue with the current service, which is a 5-day-a-week stroke service at both hospital sites, but the preferred option is to develop a dedicated hyperacute stroke service at Carlisle, which will enable us to get the necessary care, specialist care, to patients suffering a stroke more quickly than we currently can. This slide again is for context, and I want to stress first and foremost that the changes that I've talked you through this evening, the proposals, are not actually about saving money. It's a tiny amount of money that would actually be saved by the changes. The changes that are being proposed are about improving the safety and quality of care. That doesn't mean to say that we don't have a significant financial challenge in the NHS. Our overspend now is in the region of £70 million a year, and if we were to do nothing, that overspend would increase to over £160 million a year by 2020. So in the background, there's an awful lot of work being undertaken to look at more efficient ways of working, new ways of working, that can bridge that financial gap. But the changes that are being consulted upon will only actually contribute somewhere in the region of £2 million worth of savings. It's about patient safety and it's about quality of care that we are bringing these proposals to you tonight. So the future for West Cumberland Hospital is a very, very positive one. We need this hospital to continue. We anticipate care returning to the hospital and fewer people having to make the journey to Carlisle. In particular, we anticipate returning acute surgery, some trauma care where it's safe for it to be provided at West Cumberland, more planned surgery or elective care transferring from Carlisle to West Cumberland, and a new diagnostic suite. So we anticipate somewhere in the region, if these proposals were acceptable, somewhere in the region of an additional 7,000 patients a year moving back to treatment at West Cumberland. That concludes the presentation. I shall hand over to Andy now to take your questions.
Okay. Right, you've spent enough time listening. It's time to hand over to you for your questions. So I'm more than happy to take questions, comments, or just contributions. It would help me if you told me whether it was a question or you just making an observation or contribution. Also, to remind you that it would be really useful if, when you do speak, that you put your hand up so I can get the microphone to you. And also, to remind you that this is being recorded for the consultation record, so we have a record of this event. So if you would like to, beforehand, if you'd give me your name and your organisation or who you represent, that would be really nice. But there's no compulsion to do that. So if you want to make the contribution anonymously for the record, that's also fine. So as we go through this, we'll find out how we're going to manage this process. I have to stick my head around a bit there, so make sure I see that. So hands up for the first question, please. Okay, so we've got one there. So, Jay, thank you.
I'm Alison Harker. I represent myself. I have to confess, I didn't read all of the 36 background documents which appear on the website, but I did read enough to not be able to find details of the costs of what's proposed for the new way of working, and also how you intend to recruit and retain staff for the new way of working in light of the difficulties that have been for many years in recruiting and retaining staff for the current model.
Okay, thank you. So it's about costs and recruitment and retention. Who would like to take that first question? Yeah, thank you, Rod.
Probably because I think we all suffer recruitment difficulties, but I think the recruitment particularly sits on the acute trust, so I'll comment on that a bit. And I might just ask though, by new ways of working, do you mean the whole package of the reconfigurations, or do you mean the new ways of working as it's referred to in the document, in terms of the new model we're putting into Whitehaven for managing medicine, essentially, or emergency medicine? I'll just clarify that.
I mean the whole new way of operating,
yeah, okay.
The integrated care package, because as far as I'm aware, it's not just the health service who have trouble recruiting and retaining staff, it's also the voluntary sector and the social care providers.
Right. That's fine. So that broadens it out a bit into my partners in the community. So I'll just comment on the recruitment difficulties, though, for the acute trust, and just make a couple of observations, perhaps. In order to sustain our current services, we are employing a lot of locum workforce. And that's one of the, based on a couple of factors. One is the uncertainty, and the other is the way we're currently working our staff. And I can come back to that through the meeting if necessary. But they are expensive, and they don't give us the same continuity of care that permanent staff would give us. So one of the objectives of getting some certainty around the way we're delivering services is to, in essence, make this a more attractive area to come to, and particularly refer to some of the new models in Whitehaven for the staffing, particularly not just for medical staff, but also for physicians' associates and others to do some of the medical jobs. So it's part of trying to get certainty. It makes it more attractive for people to come, and therefore we stop operating an expensive and uncertain model delivered by locums. So that's the acute trust broad brush. I can give you more detail if it comes up through the meeting.
Yeah, and I'd be happy to talk a little bit about the vision for integrated care communities, because it's the ICCs, although they're not formally part of the consultation, that will actually be the engine room that should bring about many of the changes that we're looking for. In some respects, there's no brilliant new idea about ICCs, because they are pieces of work that have been done in other parts of the UK, other parts of the world, and actually also in other parts of Cumbria that we're seeking to learn from. The big idea, as Stephen said in the presentation, is to make a single team of doctors, nurses, allied health professionals, social workers, caregivers, responsible for the budget and responsible for the care and the keeping well of a defined community of people. The consultation document talks about populations of between 20 and 70,000. So the idea is these are natural communities as far as possible that have an identity. And we bring the health and social care professionals of that community together. At the moment, you might be excused for thinking that the National Health Service is one big happy family and happy organisation. Although we are happy in many respects, we actually work for different organisations, and those organisational boundaries create huge problems to clinicians on the ground, because we're working in different organisations with different policies, different processes, different rules, different regulations, and that creates boundaries that make life difficult for patients, and some simple things like case notes and clinical records not being transferred straight away, so patients have to tell their story several times, which is time consuming, as well as frankly infuriating. So the big idea about integrated care communities is to bring those people together, break down the boundaries, give the professionals working with the community responsibility for the community health and the budget for it as well. So the incentive for people working in that system is to keep their people well. And if people are poorly and do need to go into hospital, to help support, bring them back out of hospital much more quickly. And based upon the best national and international evidence that we have, we think we can save a lot of bed days from doing that, and that will mean that more money can be invested back into the community services, so pay for more doctors, nurses, and therapists to keep people well for longer. And we recognise that we've only got a finite pot of resources between the different organisations, so it makes absolute sense that we bring them together and make them work. As I say, we've got evidence of this working, and we have a couple of pilot projects looking at how we can do this. And one of the first to produce evidence on this is the work that's been going on around the Millom community in the south of Cumbria. And we've shown there that simply by bringing people together, the professionals together, we can reduce the number of journeys that people need to make out of Millom to get care by around 40%. So we can save people travel time and expense of moving away, because they can get their outpatient appointment, their diagnostic services, their care packages and rehabilitation in their own town rather than moving away. And our hope is that places like Wigton Hospital can become the facilities and provide the space and the rooms that allow this to happen, so that clinics can take place there, diagnostic services can be located there, rehabilitation services, and so on and so forth. And I realise that that people locally haven't had the opportunity to see this in action, but we've seen evidence, as I say, both in Cumbria and outside of Cumbria, where it can work. And if it saves people journeys and keeps people well and healthier, then it's a good thing to pursue.
Thank you for those answers. I've got a question down at the front. I've got one over there and a gentleman over there. So we'll take yours first, then I will come to you.
Right, my name's Sadie.
Can you wait for the mic, please? Sorry.
My name's Sadie Haley, and I'm representing myself and my family. You mentioned challenges in recruiting and the expense of locums. What sort of contracts are offered to new consultants? I've heard of some who would have loved to come and stay here, but were only offered 6-month contracts. And as they said, as somebody who's got a family, there was no way he was going to stay for 6 months when he wanted to be settled with his family. So that's one reason why we're not getting them. And the other one perhaps is because of the poor inspection results, that we're a failing hospital. Lots of consultants don't want to come because they don't want that on their CV, that they're working at a failing hospital. So what's going to be done to do that? I mean, a lot of money is being spent on our chief executives. I mean, Mr. Ames, £225,000 per annum. He moved from a job where he had £202,000 per annum. I don't know what all the other executives get, but it would be interesting to see all that in one big sum. Why do we need them all? I've spoken to Mr. Eames, and all he did was lie to me and say the only reason that you know that they're going to be cut is because the media are lying.
Well, just at that point, he's not here to defend himself, so we can't accuse the man of lying. So, yeah, I'll take your point now. Thank you. Yes, please.
Shall I take that? First of all, if we advertise a substantive post, a permanent post, we would never appoint people for just 6 months. The 6-month duration posts are almost all, I think, locum posts. So, yes, so. Oh yeah, no, I'm fully. In fact, you've said two things I'm fully in agreement with, and they might bring out some of the things we're trying to do to recruit. So, firstly, just to answer that, substantive posts are for life or until retirement, and it would be our main driving aim to have all of our posts filled by substantives. That's the first thing. We advertise for substantive posts and often get no applicants. So that's the first thing. So we need to make it more attractive. And one of the things you've connected in is the attraction or non-attraction as a doctor for working in a failing hospital or failing system. And I do get rung up by prospective candidates trying to ask me, what do special measures mean? And what do CQC in special measures mean? And it is our driving aim at the moment. We're due another inspection. Our main aim is to make us get out of special measures. In other words, take us out of special measures, because it's a phenomenally inhibiting point as far as recruitment. And it also actually denigrates our own staff who are working really hard in the system. And I think it's a label none of us want. So you've said two things which actually I fully agree with.
I'd just add from the point of view of our organisation that, again, we do not advertise 6-month temporary contracts. We look to recruit substantive people who are going to be committed to the area and to the services for a long, long time to come. I want to share with you 3 success stories, if I may, on the topic of recruitment. Firstly, general practitioners, because every sector in the healthcare arena in Cumbria is facing challenges recruiting, and general practice is no exception. But we've been hugely successful with GP colleagues in Millom in recruiting new partners into the Millom practice. And that was because, amongst other things, the community helped support the practice in bringing doctors in. And actually, there was a fantastic video produced by the people of the community which showed the attractions of the area, the friendliness of the people, and the warmth of the welcome they would get when they relocated into that area. And that was phenomenally positive and attractive. Second success, and Rod hasn't let his light shine on this at all, and he should have done, because actually I believe, Rod, that your surgical teams are now fully recruited to. You've got a full band of consultant surgeons in Cumbria, probably for the first time in a long time. And that's a tribute to colleagues working in the acute trust who've got a clear vision for what surgical services can do and have gone out and recruited really good people into those posts. And in my organisation, we've had a success in recruiting to all of the posts in palliative care for the entire population of Cumbria. For the first time that's ever been done. And the reason why that was successful was because we all, in the health and social care community, got together and designed a very good vision for how that service should look. And we all got together, put our heads together, worked with local universities, and we found people who came in. And success actually breeds success. When you start getting people in, the word gets out that this is a great place to be. And that's what we need the community's help to do as well. We need you to go out and tell people what a great place this is to work. And the fact that there must be, 120, 140 people in here tonight shows that in this community there's a huge passion about healthcare. And if we worked together, actually I think we could do a lot.
Thank you. Lady at the back there.
Oh, hi, I'm Bronwyn Cutts. And with the greatest respect, could I have some short answers to the 2 following questions that I'm going to ask? First of all, it was the First Lady that asked a question. I don't believe it was actually answered fully, and it was about the budget that was in line for the new proposals. Secondly, are you using an outside consultation company in this consultation? And if so, are they up for a percentage of the savings that you'll make to what we're assuming are the cuts? Thank you.
Short answers. So, first of all, in terms of the funding of these changes, it depends which element of the changes we're looking at. So, we're not assuming anything at the moment, so there hasn't been a full costing of some of the changes that are needed to be made. We have put in bids for transition funding to help us to establish the integrated care communities, and I think that amounts to a bid for around about £4 million a year is what we would like to try and attract by way of new resource into West, North and East Cumbria to finance those new communities. I think it's important also to mention those integrated care communities, once successful, will help us to recycle the significant resource that's already in the community as we move resource from secondary care out into those integrated care community teams. And then your question about a consultancy going to get a share of the savings, not as far as I'm aware, no. I can put your mind at rest there.
Gentleman here with the jacket on.
That's lovely, thank you. A number of comments and probably questions. My biggest concern is the closing of the 28 beds at Wigton. That's the biggest concern. It might be more than 28. Wigton has always been known as the care centre of Cumbria. And I don't like the idea of decapitating it, and that's what you're planning to do. If we can look at our area generally, Wigton is the hub of North Hallidale, or better still, of the Solway Plain, and you can look at any map, and the distances are large. I mean, some of you probably know the area. I mean, from Port Carlisle right down past Allenby, when you go east towards Penrith, the other side of Zebram, right along the northern fells. And the Wigton Hospital covers all this area. Now, through it, we've got our transport links, naturally, to Carlisle, which is 11 miles away. And the Carlisle Hospital generally had overspill to Wigton. I don't know what's happening now, but we've got stacks of accommodation. It can be used. Now, going west, we've got the collection of towns there, Keswick, Cockermouth, Maryport and Workington. Workington's 20-odd miles away. Now then, I've heard comments about 24 and 70,000 people. If you look at a town of 200, 300, 400,000 people, you've got a hospital area normally of about 20 square miles. Now then, people can get to that hospital quite easily. They can walk, taxi, public transport, it's all available. When you look at our area, we're talking about 4,000 or 5,000 square kilometres. Now then, when you go to Brookby Sands, you're talking about possibly 50 miles round trip to go to Keswick. Now then, they can't walk. They've got no public transport. Can't afford taxis. How are they going to get there? Either to go into hospital and to get picked up, or people to go and see them and visit them in hospital. How are you going to do it? I mean, you've got to equate the hundreds of square miles, what we've got, 400 or 500 square miles around Wigton, with hundreds of thousands of population. So, as far as I'm concerned, I would think 300,000 or 400,000 people equates to 300, 400, 500 square miles in our area. So, the way you work in 20 to 74,000 people isn't the right equation to be using to try and knock Wigton. And touching on the people recruitment, it has been highlighted. I mean, if you're going to, Wigton's been under the set for a while. And there's no way in the world will people come, because they've got no job guaranteed. So what you actually do when you're just destroying it. And and what you're actually doing also, you've got to have the county council involved here and look at general care. When I referred at the start, the care centre of Cumbria, Wigton's been known as, and you're going to destroy it. You've got to incorporate the county council somewhere, because of all the little care homes we've got in Wigton, and there's a lot, you know, of all types of care. And it should all be brought in together, and please don't destroy one.
Thank you very much. Thank you for that comment. Just offer the chance for the panel to make some responses to those comments. Thank you.
Just to say that if the preferred option is followed, the thing that will change in Wigton is that the beds that are open will close. There are 14 at the moment beds at Wigton Hospital, but there are 14 open. No, 14 that are open and patients can stay in them. That's the number. The maximum number, I understand, is 19 as well. Now, I'm sorry, but that's the information I have. You may go and have a different view. Yes, the hospital itself will always remain. Whatever option we take, the hospital will remain and will continue to be a valuable community asset. It will continue to provide healthcare and social care. That, I stress, is only if the preferred option is followed. If another option is taken, so be it. As I understand, the difficulty with keeping beds in Wigton Hospital is because the building is an old one. And despite the incredible efforts of the staff there and the lengths they go to, old buildings are not fit for purpose in the 21st century. And the people in Cumbria deserve better than that. And our advice from our estates experts is that in order to make the buildings safe and fit for purpose to provide hospital care for the 21st century, it would need to be rebuilt.
Okay, thank you, Andrew.
Why not? That's the perfect idea. Quite, and at a reasonable cost.
Yeah, okay, yeah. Sorry, Stephen, you want to...
I think, so that's the point I was trying to make at the beginning in the presentation, is that we do welcome other suggestions. And I think the connection with care home beds and the capacity of care in the community is a really important point to make. So we're not dismissing the notion of a future for the community hospital. It's just that the current model is probably not right. So, you know, how we can engage with you and your ideas for what your community needs, I think is a really important development, if that is one that follows on from tonight.
Gentleman wants to make some
comments. Thank you. Joe Cowell, Wigton Town Councillor and Allerdale Borough Councillor. Unfortunately, my friend here has said a lot of what I wanted to say, but I will say one or two other points. Primarily, we are up for a new build in Wigton. I think the consensus would be a big yes. And I think that's the only way we can go, because you are trying to close down Wigton Hospital as far as we are concerned. This is only the start of it. We had a battle in about, I think it was 2000, when you wanted to close it down as well. Unfortunately, we won that one, and I hope we're going to win this one as well. You're talking about the budgets. As far as I can make out, the government, the present government, are going to put £10 billion. That's £2 billion more than what the NHS asked for. Where's all this money going to, and who's spending it? There's lots of money available. I would appreciate a comment on that. And the other thing was, you were talking a lot about West Cumbria. Well, the people here tonight are mainly local people, and we are concerned primarily with Wigton Hospital and Carlisle Hospital. And I think you're throwing a bit of a smokescreen over by bringing everything else in to this meeting tonight. So if we could concentrate locally, I think it would be very much appreciated.
Thank you. Okay, I'm going to take... There's a gentleman, Jay, there's a gentleman behind there who's been trying to get... No, I will come to you in a minute. I've got you here. Yeah.
Thank you very much. Tony Markley, I'm Silloth Town Council, Allerdale Council and Cumbria County Council. I represent a lot of the ward, right down from Silloth, right down to Bonus and Solway, Park, Carlisle, etc. You've used words such as inadequate, staffing, decisions, numbers, money. These are people we represent, people. We have lots and lots of garages to repair cars and vehicles, so we need hospitals to repair people. People are what make this planet go round. You have said in this document, you've got a document full here that says you've got staffing issues. Then you have a gentleman there who turns around and says you've got a successful recruitment policy. What is it? What is it? Are you either short of staff, you're not short of staff? In the private sector, if you are wanting people to work, you will train them and employ them here. You bring your own people here, train them, employ them. I can't get away with the staffing issues. Bring staff in. Utilise what you have, and you have good hospitals in this county. You have 500,000 people, 807,000 kilometres of roads, and 40 million tourists that visit here. So we need these hospitals. So please, make sure you use what you've got, Use it adequately and use it better than what you've got and manage it better and get more efficient for these people and residents of this county.
I'm going to ask the panel to comment on that because there's some really emotive talk in that and some really definitely heartfelt and widely supported by the audience, I'd say. Yes, absolutely. So I'm not sure that there's a question in there, so I'll just say that we'll endorse it, but I'll ask the panel for any comments that they may want to make.
I'll pick up a couple of the points because I think they're well made. Efficiency savings. I mean, the challenge is for us to use the health dollar as efficiently as possible. And quite a lot of the business case that's behind this. I mean, we're trying to describe some of the clinical changes, but the sum total of savings from the clinical changes is almost nothing. It's 2.1 million, and a lot of this business case that's there is about efficiency savings and making basically savings on the way we do things and the way we procure things. So first, I'd just like to pick that up. Secondly, train local, keep local. And I think that's point's also well made, and why has it taken us so long to think that? But certainly the training we want to do in, just to pick one example, I won't be long, the UCLAN, so the University of Cumbria, Lancaster, Central Lancashire, sorry. You might get that wrong in a public arena. The idea is to train, for instance, the physician assistants and also have medical students coming through. And the providing scholarships and providing the local input, particularly from some of the areas of Cumbria that we think people will stay if they're trained there, is part of our objective. So I picked those points up, and they are points we've picked up as well. Thanks.
Yeah, to pick up your point, because you came back to me on the success stories that I gave you. The point about giving the success stories is that we have them, and we need the world to know that we have them, because success will bring more success to us. The problem that we have is that we have huge places where we're not successful. We've talked about children's doctors. That's one example of a difficult situation that we've got to recruit to. And my point about bringing up the success stories is that we need to learn from them and learn what made them work, and it was a combination of different things, actually, and then transplant those ingredients, as Rod says, building relationships with universities, with medical schools, and so on. You know, there are schools in Cumbria that do not actually send kids to universities to study medicine. And we've got to do something about that to raise the aspirations of our young people and support them to do these careers, because the international evidence says very strongly that if you were born, brought up, or trained in a rural area, you will work in one. You're more likely to work in one when you're qualified than somebody that was brought up and trained in central London. So we need to grow our own.
Thank you. I've got a question from a lady over there, and I will return to you. That's some more, yeah.
Hello, I just wanted to make a bit of a comment really, and there is an issue that I know I'm not asking you to comment on because it is a situation that happened to one of my friends who fell. She stopped breathing, was taken into Carlisle. There was not enough staff on to deal with her. She was given a lot of medication which caused her to fit, and her family had to stay in overnight with her because there weren't enough staff and video her having fits in the ward. Now, that is completely unacceptable. There may be positives, and the GPs in Wigton, for example, are absolutely fantastic. But I moved 300 miles away from my friends and family to work for the council here, to serve the people of Cumbria and to help in any way I could. Surely the least you can do is to try and keep me, my colleagues, my friends, and the residents here safe, and it's really not acceptable, the standard of care that is provided at the moment. So to go again to ask you that question, What are you doing to recruit sufficient people? There wasn't a cardiologist for my friend until 3 days after she had her heart problems, and she had to wait for someone to come over from Newcastle. That is not acceptable.
Okay.
What are you going to do?
Okay, thank you. So back to the panel.
Just to, I mean, I won't comment on the details because there's not enough and it would be unfair. And firstly, I mean, my main objective as certainly the medical director in the trust is patient safety, and working with the director of nursing, we consider that our first principle of you know, how it's our mantra essentially. So it always upsets me when I hear stories that reflect that we don't provide good care, and I'll take that on board. The second thing is that in terms of recruitment, we're going out to international, national recruitment, trying to attract people, as we've said, trying to grow people locally, but that'll take many years. In terms of recruitment, we have teams working on it, and we've put a huge amount of effort, and we do basically work through all avenues we can. So it's all I can say really in response.
And as the commissioners of these services, you know, we have a responsibility of overseeing the quality of care that's received by the people of West, North and East Cumbria. And I know we've already touched on this evening, but it's almost a vicious cycle, isn't it? As the services are poor, the rating is poor, the regulator, the Care Quality Commission come along and they feel the need to put the hospital in special measures. It makes it even harder to recruit people, clinicians, to those vacancies. So what we have here is a whole system response now to the challenge. As far as we're concerned, it's not just the challenge of North Cumbria University Hospitals, it's the challenge of the whole health and social care community to work as one to resolve this. No one organisation is going to be able to do this on its own, which is why we've got the shared vision. It's why we absolutely believe in the need to make our community an exemplar for caring for people in what are a very unique geography. Remote communities, dispersed, rural. But if we can achieve that vision and we can lift our main hospital provider out of special measures, and we can then begin to attract clinicians to attractive jobs because they will buy into the vision, then we can lift the whole health and social care system out of the malaise that it's in, perhaps in some quarters at the moment. But your points are very valid, and as I say, it's breaking out of that vicious circle as a whole system, not just as one entity, not just as one provider.
So I've got three questions, three people. So this gentleman at the back there, please.
You'll have to hold that for me. Yeah. My name is Colin Reid. I've worked in Wigton Hospital for the past 23 years. You asked for a viewpoint. My viewpoint is about retaining beds in Wigton Hospital. But the first point I want to make here is that Wigton Hospital is 20 minutes away from the Cumberland Infirmary. I have a friend in Wigton who works in the Cumberland Infirmary and has sometimes to be on call at night. And if you live in Wigton and work in the infirmary, when you're on call, you are allowed to stay at home because officially the infirmary say Wigton is no more than 20 minutes from the infirmary. Now, the reason this is important, I'll give you an example. I turned up at the infirmary one morning, a couple of years ago, for an operation. At the last minute, the operation had been cancelled because of bed blocking. Bed blocking is an expensive business. Even if you don't have the operation, salaries still have to be paid to everyone concerned, and you still have to repay the borrowed money that's been spent on the operating theatre. So a few weeks later, I did manage to get my operation. I had one operation for the price of 2. I'm sure this sort of thing is adding to the money problems of the Cumberland Infirmary. The word I get from there is there are 40 beds blocked every week. And Wigton is only 20 minutes away. So whatever you say about any other community hospital, and I wish good luck to every community that's arguing for their own patch, Wigton is the best placed hospital to relieve the costly bed blocking at the Cumberland Infirmary. I have been round and counted them. We have at present in Wigton 19 beds. I remember when we used to look after 30 patients. 30 patients. And when we had 30 patients, the hospital wasn't as crowded as the Cumberland Infirmary is today. We still have the ward space. We need the staff, and we can be back to looking after 30 patients again. My second point, I'm not going to go over again the point that has been well made about the area that Wigton Hospital serves. But I'll say that in an area like this, caring for people in their homes sounds good. But the reality is that Wigton Hospital has patients who have been waiting for months for care in their homes. We have had a patient in Wigton Hospital wait for 8 months. 8 months before care at home was available for her. And because the social services cannot cope with them, the health service at Wigton Hospital has to look after them. What happens to them if you take the beds away? I'm finishing now. What is happening at Wigton Hospital is the beginning of joined-up action between the health service and the social services. And it points to the need for joined-up thinking and joined-up funding. This isn't my idea. Much cleverer people than I have been saying this for some little while. And I finish with 2 ideas on this consultation document. On page 29 is the idea of substantial capital investment at Wigton. Now that idea has just been ruled out of court from the very beginning. So let me remind you of another idea on page 31, that there should be substantial capital investment in the building of a new community hospital in the Carlisle area. And remember, we are 20 minutes down the road. And this idea, according to the research, would have, quote, the greatest financial impact, not in the short term, but it will have the greatest financial impact. And I would suggest that these 2 ideas should be combined by joined-up thinking and joined-up funding between the health service and the social service, and that it should be done at Wigton. Thank you.
Thank you. Thank you for a very thoughtful and well-considered set of comments. There are 2 points there you're making about the proximity of Wigton and the fact that it can service demand, and the other one is about the joined-upness with social services. So I'll ask the panel to respond.
I would just thank Colin for the thoughtful comment, which actually jumped in before I was going to say something, because Colin started off talking about bed blocking in the infirmary, and I'm glad he also mentioned bed blocking in the community hospitals. Around 1 in 5 of our beds have that issue. And I think it's a terrible term, bed blocking, because actually what it means is there's a person there who's in the wrong place. They need to be somewhere else where they get more care that's appropriate for them. It's usually a vulnerable person, it's usually an older person that's affected. And we do know that older people's health actually can deteriorate in hospital because they don't get the level of activity, they don't walk, they don't move around. With the best will in the world, the staff can't stimulate them to the same extent as they can be stimulated in a rehabilitation facility. So there's a huge issue there, and I think that is the vision for integrated care communities, that we do bring the health and social care budgets together so that people can start, the professionals can start with the community to plan the care, so that it is more joined up, so that people who do need residential beds get the residential bed much more quickly. People who need care packages and rehabilitation packages at home can get them more quickly, so that we don't have people staying in an acute hospital bed or a community hospital bed any longer than they need.
Okay, so if we could just return to the point about the proximity to the infirmary of Wigton. It's kind of left by
Geographic question, but yes, the point's well made. It is close. We're trying to put together a package of, I think the whole thing about joined up thinking, and you're quite right to observe one of our biggest problems in the acute trust is getting people to the right place of care. So we don't want them to be with, people deteriorate in hospital. They're exposed to a range of infections that are, difficult to eradicate and the like. So we want them out back in the community. And whether Wigton's the right place, I think that's the whole point of this consultation. But I take the point, it is only 20 minutes away, and that today is very small distance compared to the other distances in Cumbria. So well made.
Anyone? Okay, I'm not sure that necessarily answered the question about combining the options and coming back to that, but unless you've got any other comments.
I think your suggestions, and thank you for pointing out the suggestions that are in the consultation document, Colin, because I think those suggestions are very pertinent and we should be considering them very, very carefully. The idea about combining resources, as Ernest says, is very pertinent. We have a health and social care system that up until now has almost been designed against us. We have individual organisations that are striving to be financially viable and sometimes at the expense of others, which seems crazy because that tends to take attention away from the patient. What we do have, at least in West, North and East Cumbria, are a set of organisations, NHS and local authority, that are working really hard to understand how we can put organisational differences to one side to concentrate on the Cumbrian pound. That's genuine. The other point you make about capital investment, regardless of which facility it is a moot point because, once again, if there's one thing the NHS is short of, it's capital funding, let alone revenue funding. There is a limited capital pot for us to bid against, and we have bid against it. Because we anticipate whatever comes out of the consultation, there will be some requirement for investment. Now, we don't know how much of that we're going to get. So accessing capital to pay for the kind of developments that we would all like to see in our community hospitals is going to be challenging, but at least West, North and East Cumbria is at the front of the queue because we are one of the earliest sites to be consulting on service changes. These service changes you will see happening across the country. At least the consultations will start probably in the spring of next year. So at least we have the opportunity to get at that funding first.
Thanks very much. I'm going to take I know people have been waiting a while. I'm going to take the gentleman. Yeah. Okay. Okay, sorry.
I'm always before my
Yeah. Okay.
May I stand?
Yes.
Right. I'm Sheila Delaney, a local resident, and also I do represent the Labour Party, and I'll bring that in a minute. I just want to agree with Mr. Reid, actually, because the points he made, and I don't like the term bed blocking, I prefer that delayed discharge because I have friends and relatives in that position, and it's not their fault, it's the fault of the system. So what I will say, where I live is actually a village, and it's got quite a lot of elderly people over the age of 90. And to me, that's why we need Wigton Hospital. And this is where I'll bring the politics into it, because you've been talking about integrated care, and I think all politicians talk about integrated care, but it's for us that sort of get the experience actually need to tell you that it doesn't exist. And Roger Liddell, who's the county councillor for Wigton, has actually asked me to say tonight that whilst the county council is obviously pushing for integrated care and it's in the process of implementing it, it just is not there as it would be felt to be described on your presentation. So if you proceed to go ahead with the proposals to close beds at Wigton, you will find that integrated care is not in there in the capacity that you wish it to be there. So I think we've got to set that point down quite clearly. And County Councillor Liddell also actually asked me to say that cuts, and Beth Furno is also a county councillor in Cumbria, is actually chair of the Health and Social Care Committee, especially in relation to adult social care. There are cuts to social care budgets. So what we don't want to see is, we know the NHS has difficulties in Cumbria financially, and we know you want to move ahead, but actually we can't be shifting budgets from one place to another because it might not be sustainable in the other place. So I just would request, personally from my point of view, that we put some realism on that. In relation to the things that Mr. Reid said, and I'm sure my neighbours won't mind me saying it, they could not get into Wigton Hospital, and they were both waiting to come home or waiting to be discharged from Carlisle, and they could not get into Wigton Hospital. Both people aged over 90. They couldn't get local care homes and had to, if you like, go out west or further east to get care. So it isn't satisfactory, and maybe that 20-minute proposal of a building 20 minutes from Carlisle is a very good idea. The other thing that I will say, and this is again a problem with a rural community, because Wigton is the hub of the rural community. You can have villages out west, and you've heard people speaking from Silloth, and we're speaking from towards Penrith, but not that far, maybe 8 miles away. This is our hub. But where do you get care assistance? Tonight on the news, we heard people talking about the financial viability of care homes and the funding that the county councils can give to care workers. It's not there. So what are they going to do? Are they going to travel 8 miles out to Wigton, 13 to 15 miles to Carlisle to come and treat somebody in a rural community like mine? And I'm not saying we're packed with 90-year-olds, but, you know, I would say what we see in my village is no different from the villages round about. So that's what I want to say about that. So that's rural communities, care assistance, and actually your integrated care isn't in place. What I would like to say also is that where we are losing money, and I've spoken to a consultant surgeon about this, maybe they're not working there now, is we're sending people away to get new hips to places like Hexham, we're sending people away into Lancashire. Surely that's money we're losing. Maybe somebody can educate me. That's money we're losing. And it's also activity we're learning, because you can't have a hospital educating new people if you don't have the activity for them. You're supposed to keep doing it to get better at it so we don't get these inadequate care. Because believe you me, the next thing I'm coming to do is my personal experience, and it's not very nice sat in a hospital looking at a great big screen TV and it's going inadequate, needs improvement, safe, not safe. And that's what's coming round on the screen. So it's not a pleasant thing. So that's what I would say about maybe we need to look at ways of increasing our capacity in areas which are easier to perform, actually. And what about bursaries for nurses? Because that's the other thing that's going to start killing recruitment. I think there are plenty of women, I'm not necessarily talking about young girls, I think there's women here in this area that could go forward and be nurses. You know, what people say to me when they visit me, because I come from Lancashire, and men, aren't they friendly? Yeah, you're right, sorry. Aren't they friendly up here? And, you know, you come into Wigton and you can't move off the street. Once you get to know people, they won't stop talking to you. So, you know, they're the sort of people you want for nurses, aren't they? So perhaps if somehow you could get funding so that people didn't go for loans, and 40-year-olds or 30-year-olds, they stay here. They don't go anywhere, do they? Because they've got families. And I will finish in a minute. Because the last thing I want to say is I was in hospital for some very serious surgery. And what you see standing before you is actually somebody that went into Carlisle and came out of Carlisle and recovered. So I have to compliment the surgical team on that. And I will compliment them. And I'll also compliment your nurses. Bit of a problem there, they work 12-hour shifts, which shocked me. And I don't know if that's not efficient. I don't know where you're going to make your savings, because a 12-hour shift for a nurse is pretty good. But half of my surgical ward consisted of people from West Cumbria. So be careful what your decisions you're making, because if half the people coming from West Cumbria and you shut down accident and emergency overnight at West Cumbria, because they were coming in at night, you don't get much sleep on a hospital ward, which is another reason why you want to get out. But please, I think you need to very carefully consider the proposals you're making, because it's not quite real as you think it is.
Okay. Well, thank you very much for your comments, and I congratulate you on your recovery. Great to see you here. There's a lot of questions in there, so I'll ask the panel to take it in whichever order they choose.
Yeah, let's go with the integrated care communities question first, because you're quite right. That is the foundation upon which a lot of the assumptions have been made, and if they're successful, then there will be success. If they're not successful, then I'm afraid we're going to be in difficulties still. There is work actually going on about the integrated care communities. You can't see it because it's not a building that's being built, but there are teams being built. We have people in place trying to bring those teams together. And I just wonder if I could pick on my colleague, Dr. Craig Melrose, who's Associate Medical Director for the Community Care Services Group, and he's leading on some of that work, and he might be able just to give us an update as to what's happening with developing the ICC teams.
Thank you, Andy. Yes, hello, I'm Dr. Craig Melrose. I'm a GP. I used to work in Wigton. I was trained in Wigton. Wigton made me the doctor I am today, thanks to John Honeyman. So, yeah. So we are doing a lot of work at the moment on actually working out what it is an ICC is and how it's going to work, how it's going to make a difference. And it's really all about bringing all of the professionals, as has been said already, all the professionals who work in and around a community together. So we take away the barriers. So the general practitioners, the community nurses, the social carers, the allied health professionals like physios and OTs, all coming together and working in a way that means that they share the responsibility, share the responsibility for looking after the patients in their community, working very closely with the people who look after the social aspects of patients' care, so the home carers, families, friends, because actually, as you pointed out, we've got a lot of people in our community, adults, ordinary people who are getting older. The 90-year-olds are becoming commonplace. And to manage that growing size of population, that changing population as we all get older and we all get more needy, to manage that and actually to look after those people, it's going to require a team effort. And I think that healthcare on its own can't do that, social care on its own can't do that, even healthcare and social care together are going to struggle. We need the whole community to help us, and friends and families help us look after all of us as we get older. But the integrated care communities should remove the barriers that stop us from doing that effectively now, with the handoffs and the referrals and the inefficiencies of having different organisations all contributing to the care of an individual. There was a colleague of mine went into a house recently in Carlisle and went to visit a lady who'd just come out of hospital having had a hip replacement done. He'd been called to go around because she'd been in a lot of pain. He got to the house and couldn't quite park his car outside, had to park it up the street. And when he got into the house, he found there was 4 different people in the house at the same time. There were people there from social care, there were people there from the community nursing service, there was somebody there from rapid response, and he arrived as well. And he said to the lady, "Do you know who all these people are and what they're all doing here?" And she said, "No, I haven't got a clue, but I've been stuck in this chair for 2 days, I need to get out." So it's about trying to break down the barriers, break down the things that stop us from acting and behaving efficiently, and actually just deliver good quality care.
Thanks very much. Okay, I've got a lady there, a gentleman there. I'll go over there. I've got some, so I'm going to just take this lady's question first. Can you just wait for the mic? Sorry.
I'm Pat Williams, Town Councillor. Very quick question. Where is Neil Mackay? He chairs the success regime. He's not here tonight.
Okay. Thank you.
Have we got apologies? Have we got any reason he's not here? I was going to ask him to justify his role as chair of the success regime, following his background, but I can't because he's not here to defend himself. But I just wondered why he's not here.
Yes, Sir Neil would have been delighted to have defended himself if he had been here. But it's an interesting point. What is the success regime in the context of what we're here to talk about tonight? And the success regime, so Sir Neil's role, it has been to facilitate the coming together of the health organisations in West, North and East Cumbria, as well as local authority, to try and find a solution or options to solve some of the problems that have been here for many, many, many years. Now, what Sir Neil is not responsible for is the consultation itself. That is clearly the responsibility of the Clinical Commissioning Group, which is why I'm here, and you'll find at all of the public meetings there will be a director, if not myself, or one of our clinical leads from the Clinical Commissioning Group. So the success regime is not an entity as such, it's a concept, and Sir Neil has been here to lead that work. But very importantly, this is about the future organisations that need to be held to account and need to be here talking to you about the proposed changes. And as I say, the Clinical Commissioning Group is responsible for the consultation and the decision.
Thank you. There's a gentleman there who's been waiting very patiently.
John Mattinson, I'm Treasurer of the Wigton Hospital League of Friends. And the gentleman there answered a question. He used the phrase, be an exemplar of good care for people. I would suggest that is exactly what Wigton Hospital is. Just 2 very brief examples. Firstly, my own mother, who suffered a stroke, went into Carlisle Hospital. She came out into Wigton Hospital. She had rehab there. She came out of Wigton Hospital a completely different woman to the one that had arrived. Also, a friend of mine who years ago suffered Huntington's disease. He was put in the Garlands for a while in a locked ward, completely inappropriate. He was then moved to Wigton Hospital, where he spent his last years, and he was cared for very well, which he wouldn't have, that level of care wouldn't have been available through the integrated care community in his home, because where would he have gone? To his mother's one-bedroom bungalow? She couldn't have cared for him, but because he was in Wigton Hospital, she was able to visit him day by day by day, instead of having to travel to Carlisle.
There's a lady over there. I'll come to you in a minute.
Yeah, no worries. Yeah, sure.
Thank you. Catherine Cheetham, I'm a patient. In 2011, I had an operation, and by a retired surgeon, Mr. Irons. I went to see him, and he said, "Do you live alone?" And I said, "Yes." And he said, "We won't send you back to your empty house. We'll send you to Wigton Hospital." And wasn't I glad that he did that? It was a wonderful experience, wonderful care, wonderful food, and it did help me considerably. Now, since then, I've had a fall, so I fractured my hip, and again, I was sent to Wigton Hospital, which was very, very helpful. After that, I was sent back to my home, and I had carers coming 4 times a day. Now, they were wonderful girls, and they were all so kind to me, but the trouble was that they were so stressed, and there were too few of them, and some of them were leaving because they were too stressed, and they had such long journeys to make. So I think that needs to be borne in mind, that a lot of money needs to be put into the support of carers. So although it's nice to be in your own home, Wigton Hospital as a starting point is excellent.
Right, just to save Jay's legs, there's a lady here, and I will come over to that side of the room in a second. There's a lady here who wants to...
Oh, yeah, sorry.
Sorry.
Hi, Susan Cross-Career, I live in Wigton, but I was a patient in Wigton Hospital 9 years ago. Age 50, I had a brain hemorrhage, was told I'd never live alone again. I have done for the last 7, 8 years. So I think it does need to stay.
Yeah, we'll take one more from that side, and I'll come over here.
Susan Hall, when or if the beds are closed in Wigton, who will pay for the care in the community? Is it the people themselves that have to pay for it?
So we've got a whole raft of questions that actually relate to social care in the community. I'd like to see if the panel have any comments or come back to those.
I think one of the things to bear in mind is that whatever the option is taken with respect to the community hospitals, there will always be a need for accommodation and bed-based solutions within a community for a wide variety of different things, not just hospital care, but you need residential care and nursing home care and other forms of supported care within the community. And I think one of the problems that we have in Cumbria is that we've got a relatively limited range of choices compared to other places where such choices are much more readily available. And that is one of the challenges that we're going to have to take on, is to how we can develop a much wider range of local choices for people. Because at the moment, all we have, the community hospital, the acute hospital in Carlisle or further afield, and some residential beds. And we need a much greater range of different options than there are currently available. And one of the tasks of the integrated care communities will be to identify what are the things that are needed in their communities. And that will include the beds.
Any other comments? Okay, so we've got a question from a gentleman there and a lady. So I'll take the two questions together, if I may. So you first, sir.
I'm John Honeyman. I'm a GP in Wigton. I remember, Colin, when there were 56 beds in Wigton Hospital, not 30. The lady, Sheila, talked about the closure of beds and moving into integrated care communities. I share her great concerns about integrated care communities in that the structures are not in place. They're not there yet. And Susan in the far corner there has raised the question about who would pay. Andrew Brittlebank talks about combined budgets. There's a big elephant in the room in that healthcare is free at the point of delivery. Social care is means tested. And that is a major hurdle for an integrated care community to overcome.
I'll just allow the panel to come back on that question, if I may. Anyone?
No, absolutely right. I think John's made 2 points there. One is the structure of integrated care communities isn't visible, and that's right. We have appointed people to them. They are beginning to pull people together and sort out how things are going to work. But you're absolutely right. As far as this locality is concerned, it's an untested concept. At the moment, we've got evidence from places like Millham and from further afield that the concept can work, but as far as this area is concerned, it's untested, it's still work in progress. And you're absolutely right, the other elephant in the room is who pays for social care, and it's not just about what comes out of people's mean-tested contributions, but it's about what resources are available in the county council. And as we know, and our friend from the Labour Party will no doubt mention, county council social care budgets have been squeezed. And one thing that county councils can't do, that NHS organisations can do, is they are not allowed to run up a deficit. They have to pay their way. We can, within certain limits, run up deficits. And again, that is a huge challenge and one that we've got to take back to the Department of Health and the government to resolve for us.
Okay, thank you. Sorry, we've got to come back. Sorry, Jay, before you move to the...
It's more than a challenge.
Sorry.
I think that is more than a challenge. It's fundamental. Healthcare is free at the point of delivery, and long may that last. And it's just, we're setting up, you used the word foundation, we're setting up a foundation structure, but it feels very unsafe to me at the moment. And I know a lot of my colleagues in healthcare, not just GPs, but nurses and physios and OTs and all of those of us who provide care in the community.
Thank you. So,
I'm Rachel, the ward sister at Wigton Hospital. So you're saying that the integrated care communities have to come up with the ideas of where the patients go. We have a lot of patients who are delayed discharges. So yeah, fair enough. It's social care's problem. We need to resolve that problem. That's a long-term problem. We also have patients who need hospital care, not acute hospital care, and not care at home. There's people who want to remain in hospital for end-of-life care. So where are those patients going to go? We, as integrated care communities, how can we solve that problem? We need inpatient beds. Maybe they need to work in a different way, and we can come up with different ideas, but there still needs to be inpatient beds. Because where are the patients?
thank you.
Yeah. I think you're absolutely right, Rachel. There still needs to be beds, and you've raised the issue of end-of-life care. I come originally from Northumberland, and in the part of Northumberland I lived in, we had a community hospital which 15 years ago changed its function, and it's now run outside of the health service, but it provides end-of-life care beds within what was the community hospital, funded partly by the NHS, and it does work, so it can be done. I think what we need to bear in mind is, yes, we need beds. They may not need to be hospital beds, they can be provided in other ways, but people need local beds, and it's going to be part of our responsibility to find ways of doing that if the option that's the preferred one is the one that's finally accepted.
I've also got another question. You say that the hospital isn't fit for purpose and we need to shut the inpatient beds. What would you do with the hospital building should we get rid of the inpatient beds?
I think the vision for the hospital building is to remain as a hub for the integrated care community and to provide a lot of the things that it's actually providing at the moment in terms of clinic space, but to do more of it and provide more diagnostic space and more space for rehabilitation services.
Would that not need a huge refurb and cost a lot of money?
It will need capital spending on it. Absolutely right. Yes.
So why not a new build or plan ahead, keep it open as an inpatient unit for a certain amount of time and then plan ahead for a new build to make it fit for purpose?
I think that is one of the options that was considered, and people who know more about finance and capital will be able to answer the question as to how much that would cost and where it figures in terms of affordability.
Okay. Thank you for that. If I may, I'd like to bring the mic over to this part of the audience here. The gentleman's been waiting very patiently for a while, and we've got some more questions in this group as well. So,
Thank you. Bill Goldsmith from Escott Newmarket. I think it's an absolute public disgrace that the elderly that was projected many years ago, I've known for many years that the population of elderly people is going to grow and grow. The panel must be aware of it. Who's to blame? The government? Ourselves? The panel? Or what? Who is to blame? It is an absolute disgrace. To get back to the hospital in Wigton, Escott Newmarket's a small village, and a lot of people are over 80. I'm over 80, I'm 82. And a lot of people have been taken into Carlisle Hospital. As my wife said earlier on, two of our neighbours at the same time were in there. And of course, when they were looking for discharging them because of that horrible expression, bed blocking, there was nowhere to go. They finished up in Whitehaven, in a home, away from friends. And, you know, it is absolutely terrible. And I get fed up of people saying to me, doctors and everybody who speaks to it, well, the problem is, you know, it's the number of people who are living to it. Let's have a Switzerland round the corner.
I might just pick up on the elderly bit. I think, in fairness, people have been warning about the rising elderly population. I don't think we should blame the elderly for all the problems either. What's happened is actually people are being made able to be fit and active for later in their life and longer. And what's happening is we've shifted the problems. And we do have huge technologies, and healthcare has advanced. I mean, if you want to look at the technology advances in phones, well, healthcare has also followed a huge trajectory of change. You know, the hospital we don't want to send our orthopedics to anymore because we don't want the money to go out of the economy, is now doing day case hip replacements. Now, that wasn't possible 5 years ago. When I started in anaesthetics, people would be in for weeks for operations. We get them out in overnight. So we've made huge advances. But with those advances, unfortunately, has become greater expectation, greater demand on the health service because it's not as simple anymore. So I think we've got a challenge, and it's not just about the elderly, it's about what our expectations are and how we can meet those. And we have to change things, the way we think about it, and we have to develop those new ways of working, including doing day case hip replacements, because if we can get people out of hospital, that's a great thing to do. So in comment to a couple of the things said, because I was feeling very lonely here as far as the acute trust is actually, no, we want to retain our work, we want to support the elderly, and yes, it's been predicted for many years, and I think we're coming to a point where we're having to have these discussions for that reason. Okay.
Thanks very much. We've got a lady there, and now I'll come to you. Okay. So in the middle there.
Elaine Lynch, Wigton Town Council. Two key things. Firstly, I agree so much with what so many people have said, particularly about where people in Wigton would go if the beds were closed, and the geographical area and things like that. Particularly what Mr. Reid said was absolutely brilliant, and he really put in a nutshell what I think everybody in this room feels. What I'm concerned about is the report itself and the criteria which you are using to close the inpatient beds in Wigton, and the complete lack of details about the integrated care communities. Now, the criteria you're using, and it's on page 29, as someone has already said, they are relatively, how relative is relative, old buildings, and requires substantial capital investment. The entire health service requires substantial capital investment. The integrated care communities, there are absolutely no details at all. Now, in the impact for option 1, which is your preferred option, it says that the community hospitals that no longer had inpatient beds would have important roles within the new system of integrated care. Now, you mentioned, Andrew, the inpatient, that in fact part of the integrated care would be inpatient beds. And therefore, if Wigton Hospital was going to be used as a very important role in the integrated care, it would therefore be providing some inpatient beds. How can it possibly do that if you've said in your details that they're relatively old buildings? So it just doesn't match up. The whole thing, there's just no details there at all, and that's what concerns me. Decisions, and these are massive decisions, not just for all of us in this room, but for people in the future. And these massive decisions should not be being made without details. And all we've got is a couple of lines about old buildings and integrated care with no details whatsoever. Costings. If you've got to be doing a business and doing a business plan, a bank will not lend you any money if you have not done a proper business plan with costings and things. And decisions are going to be made here, as far as I can see, without costings. And very much on shaky criteria. Okay. The only criteria I can see here is that these are relatively old buildings, and that there's no mention of, there's clearly a need for the care because integrated care are going to use Wigton Hospital. And as people have heard tonight, the care that comes from Wigton Hospital is second to none. So why are you thinking about closing something, and who in the end is going to make the decision? That's what I want to know. Who makes the final decision as to what happens to our community and our hospital?
I'll ask Stephen to take
I'll
this.
pick up your last question first. As I mentioned already, the Clinical Commissioning Group is responsible for the consultation, and the governing body of the Clinical Commissioning Group will make the decision, and that will be, we anticipate, in the spring of next year. Sorry.
Yeah, I think, actually, I'll pass that back to you, because I think the criteria were established by the CCG, the testing criteria by which the options went through the hurdles.
So the criteria that I'm aware of that the CCG have agreed is undoubtedly on the ultimate judgment of the options that we put forward in light of the feedback we get from you. So we have 4 criteria against which to judge the final recommendations that come back from the independent panel, taking into consideration all of your comments. But I take your point, though, about the initial criteria that we use to assess which hospitals would have the beds closed. So if that's a weakness, then we need to take that back and have a look at it. So thank you.
Yeah, can I just ask a question, Stephen, just to follow up on that point? So we've got the criteria, we've got suggestions from the audience that it's weak, and you've already said right through the process that there will be refinements in the consultation as they're going on. How much will that actually be, those criteria be worked up and later in the process?
Well, I think before we go back and changing the criteria, I just need to double check what all of the criteria that you use to reach the decision about what are the preferred options for the community hospitals and the potential bed closures. So if I may, I'll come back to you with more detail on that. I'm sure we have that for you.
Yeah. Okay. Thank you for that response, lady here. The mic's on its way. Hot footing down.
I'm just commenting on a comment that was made over there by a gentleman who said we shouldn't think about Whitehaven from here. I think it's very important and it's quite dangerous if we don't think about Whitehaven, because if we leave Whitehaven out of the equation, all the ambulances that end up waiting outside accident emergency and, sorry, I was going to use the words bed blocking again, people from Whitehaven. Last week, Carlisle Hospital was so full that they had to send patients to Whitehaven. So I think we've got to look at the whole lot, not just Wigton and Carlisle, the whole lot altogether.
So looking at the system as a whole.
Yeah, definitely. And then comment made over there, she's saying what's going to happen to the National Health Service. I fear with the Conservatives we could end up with none in 5 years' time.
Thank you. Okay. I don't know if the panel wants to come back to that or not.
Well, not the politics, no.
Yes, absolutely not.
Stay clear.
Yeah.
But essentially, I just wanted to say about, I'm glad you've made the point, this is a health system, it's a health economy, and we have to try and deliver some services that are very difficult to deliver, high acuity services. I mean, we've had nothing about the hyperacute stroke service tonight that really requires dedicated equipment and expertise. So we will naturally try and group those services and then use other areas, and we've discussed your community hospital, Whitehaven, for doing perhaps the gradated or graded care. So I think we have to recognise it's a health system and we're going to use every bit of the system to the best advantage.
So what is the time limit of optimum treatment for a stroke?
The time limit, it's time related, and it's obviously the sooner you can get somebody to the service, the better. That's counterbalanced, well, I was going to say that's counterbalanced by there's a trade-off, as if you can get them to a more specialised service, then you negate some of those disadvantages of travel.
Yeah, okay,
So
sorry, I don't want to close this down too much, but we're coming towards the end of it and I've got a lot of questions, so I'm going to take 2 questions, a gentleman there and a lady there. So we'll take the gentleman's first and I'll come to you. And then we'll come over to this side, right across, yeah.
Derek West, Wigton, resident. It's just an observation, really. The distribution of care beds seems to be rather bizarre geographically. In 3 of the options, there's no care beds at Wigton and there's no care beds at Carlisle. And there seems to be a thing about the A66, because all the care beds are along the A66. Workington, Cockermouth, Keswick and Penrith, apart from Brampton, which is on the A69, which seems rather odd to me. There seems to be a desperate need for care beds in the Carlisle-Wigton area if we look at these proposals. and there's this gap to be filled.
Okay.
What do you think about that?
Okay, so there's the gap to be filled. Okay, I'm going to... Here.
Oh,
Fiona Lambert, Wigton resident. I've lived here for about a year and I'm also a Labour Party activist. We do see this as a very political issue because the Labour Party introduced the NHS and we're very scared about it vanishing as you try to privatise it. Secondly, I don't know how to make any decisions really about the whole scheme because you haven't given us enough information. I don't know how to make a decision on things that haven't been costed out.
Okay, so we've got gaps, we've got costings, and we'll take one last one from this gentleman here, and I'll just take it here, this one here. Then we'll take three, and then we'll go on.
Yes, we've now learned that there's a little cabal who's going to make the decisions. 3 people, did you say? 4? Can we know who they are?
Okay. All right, so we need to know who is actually making the decisions. So we'll take them in the order about the gap, the geographical gap, first, if you don't mind.
Yeah, again, it's a hugely difficult challenge, and that's one of the things that we need to learn from the consultation exercises as to where people really want their beds to be. I think one of the problems is the community. Well, one of the problems, and one of the great assets of the county, is that the community hospital beds were never planned. These buildings and these foundations go back many years, often to around the time of the First World War, and certainly before the National Health Service came into being. And they were put in places where people left money or made endowments, and not necessarily where they're actually needed in the 21st century. And that's part of the challenge that we've had to deal with, is that we've inherited a system that grew organically and wasn't planned. I think if we had a completely blank sheet and all the money to invest in capital that we'd ever want, we would probably arrive at a very different model of where the community hospital beds would be. However, we are, as they say, where we are, and we have to make decisions. One of the points that's come out is and I come back to it again, is that there seems to be a view that we've either got community hospital beds or acute hospital beds. Actually, there are far more beds, and we need far more beds of other types in other places. We need to consider where the residential care beds are, where the nursing home beds are, where the end-of-life care beds are. And those are all things that need to be properly planned and decided upon.
Okay. So the next set of questions are about the lack of detail at the moment, perceived lack of detail, and actually who's going to make the decision on the scenarios. So, Stephen.
So let me just pick up the decision making, and I can touch on the costing as well. So the governing body of the clinical commissioning group will make the decision. It's made up of 3 lay members, GP clinical leaders, and some directors of the clinical commissioning group. So more than 3 people, and their details are on the clinical commissioning group's website if you'd like more information about them. In terms of the costing, as I mentioned on the slide earlier, the net effect of the proposed changes is, in the whole scheme of things, a small saving to the NHS of around about £2 million a year. So the changes that are being consulted on in terms of revenue costs will be cost neutral, small saving. There is some capital costs associated with the changes, we would imagine, which is why, as I mentioned earlier, that we put a bid in for new capital funding for West, North and East Cumbria.
Any other comments from the panel? No? Okay. Right, I'll take some more questions. There's a gentleman here. I'm going to try and get across the room here. So this gentleman here. Yes, I'm yeah.
Hi. I came this evening with sort of an open mind because I'm fairly sort of new to the area. I've listened to everything that you've put forward through your display and presentation, and I've listened to all the comments of everyone here, and it seems to me that you're missing a trick. Everything you highlight, everyone here points out that Wigton Hospital ticks the boxes. Okay, you've mentioned that the buildings are old. Well, dare I say it, older buildings were better built than many modern buildings. You've also said on your options, it was the second option, I believe, was to have a tranche of 5 hospitals, one of which would be a new build. Now, you cited that as being Carlisle. Well, as everyone's pointed out, it's a few minutes down the road. It seems to me you've missed a trick. There could be a symbiotic relationship between something redeveloped in Wigton that can support Carlisle, bed blocking, I know it's a terrible phrase, and vice versa. It seems to me that you've overlooked that and you've missed a trick. It's just an observation. Basically, on what you guys have said tonight, you haven't really argued your case. You've argued the case that this place needs to be redeveloped.
Yeah,
but
okay. Thank you.
You don't seem to sort of recognise that as a possibility.
So there's the potential for a changed scenario, and we'll come back to that. There's the lady there who's very keen. Sorry, yeah.
I'm Marion Mashiter. Oh, sorry. I'm Marion Mashiter. I worked for many, many years in the community, and I would like to point out that the family structure in the community has now changed considerably. When I was working, it was taken that elderly people were looked after the family as much as possible. That doesn't happen so much now because people have had to move away for employment, and the new houses that are built are so small that to try and care for somebody who wants a wheelchair, a Zimmer frame, and other aids to help manage them, they're just not practical at all. And as I say, there's a lot of single women living in homes, and they just aren't able, they can't give up their work because mother wants looked after, because they have the children to look after. And so it is quite a point. The gentleman just said about building a new hospital. I understand that the Wigton Hospital has a large piece of ground which belongs to it, which would be very suitable if you wish to make a new hospital.
Okay,
and as we've already been said, Wigton is the centre of a hub of a large population.
Thank you. So you make... Yeah, so you're making a point about change family structures and the option to redevelop again. Thank you. Gentleman here.
Thanks. Well, we're reaching the end of this evening's proceedings, I suppose. I'm Neil Hughes. I'm the chair of Cumbria's Health Scrutiny Committee, and I'm a councillor in Eden. Actually, the last time I was in this room was as a soon-to-be unsuccessful parliamentary candidate in 2015. But tonight, I've been entertained, I've been instructed, and I've been delighted by the wit and the insight and the creativity of so many people here from the Wigton area. Now, as chair of the Health Scrutiny Committee, which contains both county and district councils in Cumbria, I have to be extremely careful what I say tonight and throughout this consultation. Because at the end of the day, when we make our assessment on the success regime's proposals in January, we are supposed to be as neutral as possible, taking all the evidence into account. I assure you that will include everything I've heard here tonight, but it also has to include all the arguments and comments made by the success regime and the constituent organisations. But your local GP made a very, I'm looking from here, can't see, oh, he's sitting at the back, made a very salient point, and others have too. Adult social care is an essential part of this equation, and at present it is chronically underfunded by the government. So if there's one thing you could all do when you go away from here tonight, it's to lobby your MP. If you live in Wigton, that is Rory Stewart. If you live in the hinterland, it may well be Sue Hayman. But whichever party they they represent, and there are other MPs in Cumbria as well, you could at the very least ask them to pressure the government to put more vital resources into adult social care. Now, you will go away from here, and I'm sure many of you will campaign on the options you want, and that's absolutely right because you're residents and that's your prerogative. But for even the success regime's preferred option to work, that of integrated care communities, it needs a lot more money into adult social care. So please recall that when you go away tonight. Just one final thing, Chairman. The Health Scrutiny Committee actually it doesn't have the power to take the final decision on these matters, but it does have the power, if its members so wish, to refer the CCG's decision to the Secretary of State for determination. Now, from what you heard, you may not be too optimistic about the approach the Secretary of State will take. Nevertheless, we do have that potential. So we, as a committee and our officers, will be grateful for any information, any comments that residents want to make. The best way is to feed directly into the consultation, but it's also possible to approach the committee directly and do that. And at the end of the day, if it comes to referral to Secretary of State, we as the committee would want the maximum possible amount of evidence and testimony. We've heard much of that tonight, very moving. We'd want that to be available so we could put it in our submission. At present, though, we have to remain neutral. But thank you to everybody for the comments you made tonight.
Thank you. We're coming to the end of the night. I'm just going to take 2 more comments, and I'm going to let the panel come back. So the gentleman here, and I'll move. Could you just raise your hand, please?
Yeah, it's just a couple of comments. Tony Markley again, a Conservative councillor, so you got them all here. There you go, there we go. So now then, just to, the gentleman across here said that we have free healthcare. Well, I don't know about anybody else, but I think the majority of people in here all contribute on a weekly basis through the tax system. It's not free, we all pay, and we should all remember that. And the other gentleman there said, manage our expectations. What are our expectations? Well, my expectation, and I'm sure a lot of my constituents are, is to live a long and enjoyable, healthy life. And the need for these hospitals is what we need. I can say before, we have garages to maintain cars. We want hospitals to maintain people. Now, come on, get in the real world.
Okay, thank you. One last comment down here, I'm sorry. I'm going to allow someone to comment who hasn't so far.
Sorry, Andy. I think it's very important that we tell the people here tonight that we have formed a group and we are coming up with a 5th option, and we really want you to consider this 5th option. We're working hard and we're trying hard, and hopefully you will look at what we're coming up with, please. Thank you.
Thanks very much. So if you're very, very quick, I'll allow it. So, hang on.
I'd like to ask the lady from the ambulance service to make a comment. Maybe we've missed out a question that's really important.
Okay. Just a comment. Maybe have we missed a question? Yeah.
It's very lively in Penrith this afternoon. I had lots of questions, but I think the one thing that's been evident to me is the absolute passion that you have for your local community. I live in near Brampton, which isn't dissimilar to here. And I'm not sure it's as passionate, but here, I think whatever the outcome, you're a really, really strong community. And I'm pleased you had no questions for me, to be honest.
So if I could ask the panel just to make some wrapping up comments from that last set of comments and questions.
Yeah. I will pick up something. I mean, I've listened to some of the suggestions, or all the suggestions tonight, and I just make the point, this is a public consultation. health services need to be designed with you in conjunction with us, and this is one way of doing it, but it may, getting those suggestions out, particularly, you know, I've taken on board the idea that perhaps this is where to base the Carlisle Centre, you know, in one of those options is a good one. So I think those, and developing the local options needs to come about, and they don't need to be, I think you'll agree, Stephen, they don't need to be in a sort of massive business case type style. They just need to be well-formed suggestions that we can put into consultation. So thank you from my point of view.
I think just following on from that, Evelyn at the end was saying that on behalf of the Community Hospitals Leagues of Friends, or leagues, I don't know, you know, Leagues of Friends.
Close enough.
They're working on proposals to look at how the hospitals might be used in the future and how beds might be provided in the future in Cumbria. And that's one of the great strengths of a consultation, is that it brings out ideas like that which can be developed. And I don't think you should apologise for that, Evelyn. I think it's welcome that a group like yours, with your expertise, is involved in the process of coming up with new ideas and testing them. And that's what we want.
Okay, thank you. Can you say the last word, Stephen?
I've wrapped up.
It's just to echo the point I made in the presentation, and my colleagues have reinforced over the last couple of hours. We're very serious about receiving alternative solutions. What we've got is not sustainable for all sorts of reasons, and we've tried to share those with you tonight. And I'm sorry that we haven't had more detail to share with you. We tried to pitch it in such a way that it's easily digested and readily understood, but we'll take that point away about the level of detail. But I would just encourage you to keep thinking about what those alternative proposals could be, because if ideally we find that alternative that is mutually acceptable and we can move forward together, because your passion, as Carol said, in harness with the objectives we need to achieve in terms of the quality and the safety of care that we're responsible for providing, would be a very happy marriage. So please, we will take those proposals very, very seriously. Thank you.
Okay, and all that remains to say is, from my perspective, you've been a brilliant audience. Absolutely challenging, some great stuff, and I'm really heartened that you've come up with some alternative suggestions, and I'm pleased that the panel have taken them to heart. So thank you very much. We'll wrap the meeting up. I'm sure the panel aren't disappearing just yet, if you have some questions, but I would say to those people who haven't felt able to voice their opinions that there are loads of different ways that you can get involved, and look at the consultation document, which is also available in Braille, large print, and in other languages. Okay, thank you very much. Thank you.